Most people imagine arterial disease the way they imagine a clogged kitchen sink. Fat and gunk stick to the walls, water pressure drops. Eventually, nothing gets through. This picture is simple, memorable, and completely wrong. I am Dr. Warren Hung. I am a medical doctor, and I present the health programs on We Care Health. I need to correct this sink metaphor before we can talk about anything else. Because if you believe your arteries work like pipes, you will misunderstand every solution, including the food we will discuss today. Arteries are not passive tubes. They are living, responsive tissues. The inner surface, called the endothelium, is only one cell thick, yet it constantly senses pressure, chemical signals, and mechanical stress. Below this layer sits the intima, then the media smooth muscle that contracts and relaxes to control blood flow. The entire structure adapts, it repairs, it responds to injury. It does not simply accumulate debris until it blocks. The clog metaphor persists because it feels true. A person has chest pain, a cardiologist inserts a stent, the blockage opens, blood flows, the patient feels better. The story seems to confirm the pipe model. But what actually happened? The artery had undergone years of structural change. Inflammation, cellular infiltration, fibrous remodeling. The stent compressed a specific lesion. It did not unclog anything. It mechanically forced a channel through a diseased wall. The underlying biology remained. This distinction matters enormously for prevention. If you believe arteries clog like pipes, you look for drain cleaners, foods that dissolve plaque, supplements that flush fat. These concepts misdirect effort. Arterial disease is not a cleanliness problem. It is a chronic, dynamic tissue response to injury and repair. Understanding this changes what you eat, how you think about risk, and what you can realistically expect from any single intervention. So what actually happens? The endothelium suffers insult, high blood pressure, oxidized lipids, glucose, smoking chemicals. It becomes dysfunctional. LDL particles penetrate the intima. Macrophages arrive to scavenge them. Some macrophages become so loaded with lipid they transform into foam cells. These cluster. Inflammation continues. Smooth muscle cells migrate and form a fibrous cap over the lesion. The artery remodels outward initially, preserving lumen size, then eventually encroaches inward. The result is not a clog. It is a living, unstable biological structure that can rupture, thrombose, or slowly narrow. This process takes years, decades. It begins in most people during their 20s, visible at autopsy long before symptoms appear. The Framingham Heart Study, which began in 1948 and has followed multiple generations, established that cardiovascular risk accumulates insidiously. Risk factors present in middle age predict events decades later. The Heart Study, a case control analysis across 52 countries, demonstrated that modifiable factors account for the vast majority of myocardial infarction risk worldwide. These are not mysteries. They are slow, measurable biological trajectories. Yet, the pipe metaphor dominates public understanding, partly because medical illustrations simplify, partly because emergency intervention stents, bypasses seem to confirm it, partly because clogging is easier to visualize than chronic endothelial dysfunction with inflammatory lipid accumulation and fibrous cap formation. My purpose today is not to criticize anyone's understanding. It is to replace this inaccurate picture with one that actually helps you. Because once you see arteries as living tissue that can be supported, protected, and given better conditions to repair, you stop looking for magic drain cleaners. You start looking for what genuinely supports endothelial health over time. But if arteries are not pipes, what does it mean to unclog them naturally? And can a single food, even one that many people despise, actually influence this complex biology? To understand how any food could influence arterial health, we need to walk through the actual mechanism of atherosclerosis step by step. This is not simple, but I will break it into pieces. Each piece matters because the food we will discuss later acts on specific points in this chain. It begins with the endothelium. This single layer of cells lining every artery produces nitric oxide, a molecule that signals smooth muscle to relax. This relaxation dilates the vessel, reducing blood pressure and mechanical stress. Nitric oxide also inhibits platelet stickiness and inflammation. When the endothelium functions well, it protects the artery wall from the contents of blood flowing past. Endothelial dysfunction means this protective capacity fails. the endothelium becomes permeable. It allows low-density lipoprotein LDL, the particle that carries cholesterol from liver to tissues, to slip through into the intima. This is not supposed to happen. LDL in the blood is normal. LDL trapped in the artery wall is the problem. Once inside, LDL can become oxidized. This modification makes it recognizable to scavenger receptors on macrophages. These immune cells enter the intima to clean up the oxidized LDL. They engulf it. But the scavenger receptors do not downregulate. The macrophages keep eating until they become stuffed with lipid droplets. At this point, they transform into foam cells. The name describes their appearance under a microscope: foamy, bloated, dysfunctional. Foam cells accumulate. They release inflammatory signals. More immune cells arrive. Smooth muscle cells migrate from the media into the intima. They produce collagen and other matrix materials, forming a fibrous cap over the growing lesion. This cap can be thick and stable, or thin and vulnerable. If it ruptures, the contents of the plaque meet blood. Clot forms. This is how most heart attacks happen, not from slow narrowing, but from sudden thrombosis on a ruptured plaque. The artery does not simply fill with gunk, it remodels. Early lesions actually expand outward, preserving the channel for blood flow. This is why significant disease can exist without symptoms. Eventually, the remodeling cannot compensate, and the lumen narrows, or the plaque destabilizes. Either way, the process is biological, not mechanical. It involves cells, signals, and time. What drives endothelial dysfunction? Sustained high blood pressure damages the mechanosensitive endothelium. The Intersalt study, which examined over 10,000 individuals across 32 countries, demonstrated clear relationships between sodium intake, blood pressure, and cardiovascular risk. Hyperglycemia, as seen in diabetes, produces advanced glycation end products that cross-link proteins and provoke inflammation. Smoking delivers direct chemical toxins, and lipids matter specifically, the concentration and composition of LDL particles in blood. The LDL particle itself is not evil. It is essential for delivering cholesterol to cells, for membrane repair, hormone synthesis, and other functions. Problems arise when LDL concentration is chronically high, when particles are small and dense rather than large and buoyant, and when oxidative conditions in the artery wall modify them. The ratio of LDL to HDL, the particle that returns cholesterol to liver, predicts risk more reliably than LDL alone in many populations. The Framingham investigators established these relationships through decades of observation. Inflammation is not a side effect in this process. It is central. The C-reactive protein, produced by the liver in response to inflammatory signals, correlates with cardiovascular risk, independent of lipid levels. The Jupiter trial, led by Paul Ridker and colleagues, demonstrated that reducing inflammation with statin therapy benefited patients with normal LDL but elevated CRP. This confirmed that inflammation is not merely a marker, but a mechanistic participant. Given this biology, what could a food possibly do? Several things, actually. It could improve endothelial function by increasing nitric oxide availability. It could reduce LDL concentration or modify its particle characteristics. It could provide antioxidants that reduce LDL oxidation in the artery wall. It could deliver fiber that binds bile acids in the gut, forcing the liver to pull cholesterol from blood to make more. It could reduce blood pressure. It could modify gut microbiota to produce metabolites that benefit vascular health. Any food that genuinely helps must act through one or more of these validated mechanisms. The critical point: no food dissolves existing plaque. The fibrous cap, the calcified areas, the remodeled artery wall, these are structural changes. They do not wash away. What food can do is improve the environment for endothelial function, reduce new lesion formation, stabilize existing plaques, and very slowly, over years, allow some regression through cholesterol efflux and tissue remodeling. This is not unclogging. It is supporting the biology of repair. Yet, if the mechanism is this complex, and if no single intervention reverses established disease, why would one particular food, especially one that provokes strong negative reactions, deserve specific attention? The food is liver. Specifically, beef liver, though chicken liver and other organ meats share many properties. It is the Hashone most hated food I encounter in clinical practice and public discussion. People recoil at the texture, the metallic taste, the idea of eating an organ that filters toxins. Many have childhood memories of being forced to eat it. Others associate it with poverty or outdated nutrition advice. This aversion is real, persistent, and largely unexamined. I need to address it directly before discussing mechanism, because the hatred itself prevents people from accessing a food with genuine, evidence-supported effects on arterial biology. First, the objections. Liver does filter blood, but it does not store toxins. It transforms them into excretable compounds. The toxins leave, the nutrients remain. Concerns about heavy metals or pesticides in liver are valid, but manageable through sourcing. Grass-fed, organically raised animals produce liver with markedly lower contaminant loads. The nutritional density of liver from well-raised animals far exceeds any modest risk from properly sourced products. The metallic taste comes from high iron content and certain sulfur compounds. Soaking in milk or acidulated water reduces this. Cooking to medium rather than well done preserves moisture and prevents the grainy texture people despise. These are preparation issues, not inherent flaws. Now the mechanism. Liver affects arterial health through multiple validated pathways. I will explain each clearly. 1. Vitamin B12 and homocysteine metabolism. Homocysteine is an amino acid produced during normal protein metabolism. When B12, folate, or B6 are insufficient, homocysteine accumulates. Elevated homocysteine damages endothelium, increases oxidative stress, promotes thrombosis, and accelerates atherosclerosis. The mechanism is well established. Homocysteine generates reactive oxygen species, inhibits nitric oxide synthase, and activates inflammatory pathways. The Homocysteine Studies Collaboration, a meta-analysis of individual participant data from prospective studies, found that lowering homocysteine by 3 micromoles per liter reduced stroke risk by approximately 19%. Liver contains the highest concentration of B12 of any food, often 50 times the daily requirement in a single serving. For individuals with genetic polymorphisms affecting B12 absorption or metabolism, this density matters. 2. Bioavailable iron without hepcidin dysregulation. Iron deficiency is common, particularly in premenopausal women, and contributes to endothelial dysfunction through reduced oxygen delivery and oxidative stress. However, excess iron also harms arteries by catalyzing free radical reactions. The iron in liver is heme iron, highly bioavailable and tightly regulated by the body's iron-sensing systems. Unlike supplemental iron, which can overwhelm regulatory mechanisms, heme iron absorption downregulates when stores are adequate. This makes liver a paradoxically safe iron source, despite its high content. 3. Choline and phospholipid metabolism. Choline is essential for methylation reactions, neurotransmitter synthesis, and phospholipid production. The liver exports fat in very low-density lipoproteins, which require phosphatidylcholine for assembly. Choline deficiency impairs this export, leading to hepatic fat accumulation and potentially altered lipid metabolism. More directly relevant to arteries, choline metabolites participate in methylation cycles that influence homocysteine levels. A single serving of beef liver provides approximately 350 milligrams of choline, most of a day's requirement. 4. Retinol and immune regulation. Liver is extraordinarily rich in preformed vitamin A, or retinol. This distinguishes it from plant sources containing beta-carotene, which converts to retinol inefficiently. Retinol regulates immune cell differentiation, including macrophage polarization. In atherosclerosis, macrophages can adopt inflammatory or reparative phenotypes. Retinol deficiency biases toward inflammatory states. While excessive retinol is toxic, occasional liver consumption weekly rather than daily provides benefit without risk. The tolerable upper intake level for preformed vitamin A is 3,000 micrograms daily. A 3-ounce serving of beef liver contains approximately 6,000 micrograms, making weekly rather than daily consumption appropriate. 5. Complete protein and copper. Liver provides all essential amino acids in highly bioavailable form. It is also among the best dietary sources of copper, a cofactor for lysyl oxidase, an enzyme required for collagen cross-linking in arterial walls. Copper deficiency weakens vascular connective tissue and has been associated with aneurysm formation in animal models. These mechanisms operate together. No single nutrient in liver accounts for its effects. The combination of B12, choline, retinol, bioavailable iron, copper, and complete protein creates a nutritional profile unmatched by muscle meats or plant foods. For individuals with endothelial dysfunction, elevated homocysteine, or suboptimal micronutrient status, liver addresses multiple deficits simultaneously. Boundaries are essential. Liver is contraindicated in hemochromatosis, where iron overload already exists. Pregnant women should limit intake due to retinol teratogenicity at high doses, though this risk is often overstated for occasional consumption. Individuals with gout may need to moderate purine intake from organ meats. Those taking warfarin must maintain consistent vitamin K intake, and liver's variable K content requires monitoring. These are specific populations, not general prohibitions. Quantity matters. I recommend approximately 3 to 4 ounces of beef liver weekly for most adults. This provides substantial nutrient density without approaching toxicity thresholds. More frequent consumption risks vitamin A and copper accumulation. Less frequent consumption still confers benefit, though proportionally reduced. Preparation determines palatability. Soak in milk or buttermilk for 1 to 2 hours to mellow flavor. Pat dry, season simply. Sear quickly in hot fat to medium doneness. Overcooking produces the dreaded grainy texture and intensifies metallic flavors. Combine with strong accompaniments caramelized onions, bacon, mustard to balance richness. For those who cannot tolerate the texture, liver pâté or desiccated liver supplements provide alternatives, though whole food is preferable. But if liver is this nutritionally potent, why does it remain so universally despised? And how does it fit into the broader dietary patterns that actually demonstrate cardiovascular benefit in trials? Liver is powerful. But liver alone does not prevent heart attacks. No single food does. To understand why, we need to examine the dietary patterns that have actually demonstrated cardiovascular protection in large, long-term studies. Liver plays a role in some of these patterns, but the patterns themselves matter more than any component. The Mediterranean dietary pattern, as defined and tested in the Predimed trial led by Ramon Estruch and colleagues, reduced cardiovascular events by approximately 30% compared to a low-fat control diet. The intervention emphasized olive oil, nuts, vegetables, fruits, legumes, fish, and moderate wine. It did not specifically include liver, though traditional Mediterranean cuisines do consume organ meats periodically. The benefit came from the overall matrix monounsaturated fats, polyphenols, omega-3 fatty acids, fiber, and the displacement of refined carbohydrates and processed meats. The portfolio diet, developed by David Jenkins and tested in controlled feeding studies, combined plant sterols, soy protein, viscous fiber, and almonds. It achieved LDL reductions comparable to statin therapy in some analyses. This pattern contained no animal products, demonstrating that arterial benefit does not require liver or any specific food. The DASH diet, derived from the dietary approaches to stop hypertension trials, emphasized fruits, vegetables, low-fat dairy, whole grains, and lean protein while restricting sodium. It lowered blood pressure substantially, and subsequent analyses demonstrated cardiovascular event reduction. Liver was not a feature. What do these patterns share? They all improve endothelial function, reduce LDL, provide anti-inflammatory compounds, and displace harmful foods. They achieve this through different food combinations. The Mediterranean pattern uses olive oil, polyphenols, and nuts. The portfolio pattern uses plant sterols and soy. DASH uses potassium, magnesium, and fiber from plant foods. Liver contributes similar benefits, B12, choline, retinol, copper, but through an entirely different biochemical pathway. This redundancy is important. It means arterial health does not depend on eating liver. It means liver is one valid option among several. For individuals who genuinely cannot tolerate liver despite proper preparation, other dietary strategies achieve comparable results. The error is believing that any single food is mandatory, or that adding liver to a poor diet will compensate for other choices. The hated food framing in the title serves a purpose. It identifies a nutritional tool that many people have rejected without understanding. But the framing also risks the superfood fallacy, the belief that one exceptional item can override everything else. It cannot. A person who eats liver weekly but consumes excess refined carbohydrate, maintains high blood pressure, smokes, and remains sedentary will still develop arterial disease. Liver improves specific biochemical parameters. It does not confer immunity. Integration matters. Liver fits best into patterns that already emphasize whole foods, adequate protein, and micronutrient density. In traditional French cuisine, liver appears alongside vegetables, moderate wine, and physical activity contexts that support its benefits. Isolated in a modern processed food environment, its impact diminishes. Practical implementation. If you consume liver, treat it as a concentrated nutrient source rather than a daily staple. Pair it with vegetables rich in vitamin C to enhance iron absorption. Avoid simultaneous high-calcium foods, which inhibit iron absorption. Space liver consumption away from tea or coffee, whose polyphenols also reduce iron bioavailability. These are not arbitrary rules. They reflect competitive absorption dynamics in the gut. For those who reject liver entirely, alternatives exist. Clams and oysters provide comparable B12. Eggs provide substantial choline. Dark meat poultry provides iron and zinc. Leafy greens provide folate, though not B12. Supplementation can address specific deficits: methylcobalamin for B12, methylfolate for folate, citicoline or phosphatidylcholine for choline. These are second best to whole food matrices, but preferable to deficiency. The critical distinction: symptom control versus cause regulation. Adding liver to address existing endothelial dysfunction is symptom control at the tissue level. It improves biochemical markers. It supports repair mechanisms. But it does not remove the causes of dysfunction, chronic stress, poor sleep, physical inactivity, smoking, excess alcohol, or the dietary pattern that produce the risk. Cause regulation requires broader change. Liver can support this change by providing nutrients that enable physiological resilience, but it cannot substitute for it. Clinical reality. I see patients who want specific foods or supplements to fix problems that require comprehensive lifestyle modification. They ask about turmeric, fish oil, or liver while continuing to smoke, remaining sedentary, or eating predominantly processed foods. This is understandable. Specific interventions feel manageable. Global change feels overwhelming. But arterial health is not built by accumulating protective items while maintaining harmful patterns. It is built by shifting the overall environment in which arteries exist. Yet, if comprehensive change is necessary, and if liver is merely one option among many, what should a person actually do? How do we move from understanding mechanisms to sustainable action? We have covered substantial ground: the biology of arterial disease, the specific mechanisms through which liver influences that biology, the dietary patterns that demonstrate real protection. Now I need to connect these threads into something you can use not as a prescription, but as a framework for thinking about your own health over time. Arteries are not pipes, they are living tissue. This means they respond to conditions. They do not inevitably deteriorate. The endothelium regenerates, plaques stabilize. Remodeling continues throughout life. This is not optimism, it is physiology. The question is not whether change is possible, but what conditions enable it. Liver matters because it addresses specific, common deficits that impair these reparative processes. B12 deficiency is widespread, particularly in older adults and those using certain medications. Choline deficiency affects most populations. Suboptimal retinol status impairs immune regulation. These are not rare conditions. They are normal variations that shift risk. Liver corrects them efficiently. But liver is a tool, not a solution. It works best when the broader environment supports vascular health. What does that environment look like? It is not exotic. Blood pressure controlled through diet, activity, and when necessary, medication. Lipids managed through dietary pattern and appropriate pharmacotherapy. Blood glucose kept in normal range, no smoking. Regular physical activity that includes both aerobic and resistance components. Sleep of adequate duration and quality. These are the foundations. Everything else modifies them. The distinction between symptom control and cause regulation is crucial here. Taking a statin controls LDL. It reduces events. It does not remove the reasons LDL was elevated. Eating liver improves B12 status and homocysteine levels. It does not remove the reasons those were abnormal. Both interventions are valuable. Both are incomplete. Cause regulation means addressing the dietary pattern, the activity level, the sleep, the stress that produce the risk. This is harder, it takes longer, it also produces more durable change. I want to be specific about what you can realistically expect. If you currently have established arterial disease, documented plaque, prior events, significant stenosis, no food will reverse this. The structural changes are real. They can stabilize. They can slowly regress with intensive lipid lowering and lifestyle modification, as demonstrated in the Asteroid and Saturn trials using high-dose statins. But they do not disappear. The goal shifts from reversal to stabilization, from progression to quiescence. If you currently have risk factors but no established disease, the horizon is different. Here, food choices, including liver if you tolerate it, combine with other modifications to alter trajectory. The decades before disease manifests are when intervention matters most. This is the prevention window. It closes gradually, not suddenly, but it closes. For those who hate liver, this is not failure. The nutrient profile of liver can be approximated through other foods and, when necessary, supplements. The larger failure is believing that health requires consuming specific hated foods, then abandoning the effort entirely. Better to build a sustainable pattern you can maintain than to force a perfect pattern you will abandon. The call to action is restrained because the biology is slow. I am not asking you to overhaul your diet this week. I am asking you to think in years. To consider whether your current trajectory, extended over decades, leads where you want to go. To identify one or two modifications that feel sustainable. Perhaps that includes liver, prepared properly, consumed occasionally. Perhaps it does not. The specific choice matters less than the consistency of attention. If you found this explanation useful, I encourage you to subscribe to We Care Health. I publish detailed examinations of health topics with the same commitment to mechanism, evidence, and clarity. The goal is not to tell you what to do, but to help you understand your body well enough to make informed choices. Arterial health is not about unclogging. It is about supporting living tissue through decades of use. Liver can help, so can many other choices. The key is understanding what actually happens in your arteries and why.